Hi, my name is Anthony Rossi. Paul Rucci, Ashley Reeves, and I will be presenting on the McKenzie approach as it relates to utilizing exercise therapy as a method of pain intervention. The objectives of our presentation are to develop an overview of pain by answering two questions. What is pain and how is pain perceived? Next, we want to develop a basic understanding of low back pain by identifying types of low back pain, common methods used to treat low back pain, and explain how the method of exercise therapy is utilized to treat low back pain. Specifically, we are going to discuss the concept of the McKenzie approach and explain how it acts as a method of pain intervention for non-specific low back pain patients. So, what is pain? Simply put, pain has been described by researchers as a warning device or an alarm system to protect us from impending damage. A common illustration of this is when you put your hand out and touch a hot stove burner, your body will perceive the pain of you burning your hand, which will result in you reflexively pulling your hand away from the hot surface in order to avoid further injury. To gain an understanding of how pain is perceived by the human body, we can take a look at this simple illustration of the general pain pathway. When a noxious stimulus is perceived by the unmyelinated C fiber and thinly myelinated A delta fiber nociceptors at the peripheral nerve terminals, it is transduced into electrical activity. These nociceptors are stimulated specifically by mechanical stimuli, heat, and cold. This electrical activity is then transported to the spinal cord and then up to the cortex of the brain, where the sensation of pain is actually perceived. The specific category of pain that we are focusing on in this presentation is low back pain. Low back pain has been reported to be the fifth most common reason for all physician visits in the United States. There are different categories and definitions given to low back pain. One of the categories is nociceptive pain. This type of low back pain is believed to be the result of peripheral nociceptive neuron activation in response to some noxious stimuli, such as mechanical or thermal stimuli. Back pain is also commonly divided into three different types. First is acute low back pain, which is low back pain that presents with symptoms for less than 4 weeks and can sometimes be grouped with subacute low back pain, where symptoms are present for less than 3 months. Secondly is chronic low back pain, which is low back pain that presents with symptoms for longer than 3 months. Lastly, the type of low back pain that we are focusing on is nonspecific low back pain, which is low back pain that does not present with any signs of a serious underlying condition, spinal stenosis or radiculopathy, or another specific spinal cause. Degenerative changes that show up on a lumbar imaging can often be misleading because they may not correlate with the symptoms that the patient is presenting with. Therefore, patients that are suffering from low back pain that does not seem to have an apparent mechanism or cause are categorized with nonspecific low back pain. There are three main categories for the common interventions used to treat low back pain. First, non-pharmacological treatments, which may include self-management advice and education, exercise therapy, manual therapy, and psychosocial interventions. Second, complementary therapies such as acupuncture, and third, pharmacological interventions such as analgesics, NSAIDs, or corticosteroid injections. The intervention that we will be discussing is the non-pharmacological treatment of exercise therapy. Specifically, we will be discussing the use of the McKenzie approach as a method of pain intervention for nonspecific low back pain patients.
Okay, so let's go ahead and jump into the McKenzie approach a little more specifically, going over a few key concepts. It's also known as mechanical diagnosis and therapy, or MDT. It's essentially a paradigm that uses a pretty extensive patient history and repeated range of motion testing, specifically at the patient's end range, to determine patient classification and use that to then guide treatment decisions. A couple key ideas that we really want to emphasize here are directional preference and centralization versus peripheralization. Directional preference and centralization have both been found to be good predictors of treatment outcomes as far as identifying patients who will most likely respond to MDT. Directional preference describes, for lack of a better word, the idea that patients tend to have a preference for a certain movement over another. So say, for example, a patient has pain with flexion. So we're going to test flexion and then probably extension repeatedly and see how they respond. So they might have increased symptoms when we repeatedly load flexion, whereas when we repeatedly load an extension pattern, say a prone press up, they may have decreased symptoms. So in this case, they would have a directional preference for extension. Okay, centralization is a related concept, but more so with radicular symptoms. Say a patient has radicular symptoms down to the knee. So when we repeatedly load them in their directional preference, so we'll stick with the extension example, we should eventually see, and actually fairly quickly see, that their symptoms centralize or localize to the spine. So this is what we want. Peripheralization is the exact opposite. This is what we don't want, where the symptoms move more distally. Within this paradigm, if someone does peripheralize or there's no change, they do suggest testing them a few days later just to see if anything has changed, and maybe they do respond at that point. There's 4 classifications that patients can fall into: derangement, dysfunction, postural syndrome, and other. Other is essentially describing patients who don't fall into one of the previous 3 categories, but they do suggest that that is a last resort classification. Derangement is the one we're going to focus on the most. It describes your mechanical pain situations. So these patients are probably most likely to respond to MDT out of all 4 classification options. Moving on to some treatment basics real quick. Again, indications for this treatment, we're really looking for those people with mechanical pain or those that fall into that derangement classification. And again, we're also looking for that centralization and directional preference when we repeatedly load a pattern to indicate that they would probably respond positively to an MDT intervention. Precautions and contraindications. As far as contraindications go, we're looking for those traditional red flags, as well as conditions that will be contraindication to mechanical treatment, so bony pathologies, osteoporosis, RA, that sort of thing. Peripheralization is more of a precaution where we might retest them a few days later, see if they're now a centralizer. But potentially if they still peripheralize, this isn't the best option for them. So moving into our general protocol, again, we're basing our treatment decision off of that fairly extensive patient history, and then our range of motion assessment with repeated end range loading. And here we want to emphasize that the end range movement is patient specific, so it's whatever range of motion they have available at the time. However, you'll see clinically that if this treatment is indicated, that available pain-free range of motion should increase fairly rapidly. Okay, and then once we've classified them and identified that they're a good candidate for this treatment, we can progress them as indicated. So and is tolerated. So we might start in an unloaded position, prone or supine, depending on their directional preference and depending on what they can handle at the time. And then as their range of motion, their function improves, we can start to load that pattern a little more. So now we want to think about how this paradigm might work. We'll emphasize the how do we think this works because we really don't know. There's a couple factors that we do want to consider though. So first of all, where the pain is coming from. They found in some studies that there are changes in nerve fiber distribution and tissue properties in discs that have been painful for individuals. They see evidence of healing or previous inflammatory processes. So this is potentially increasing our pain perception. Okay, but we also do need to note that imaging and symptoms don't often correlate. We've heard that several times. But when we look at the annulus fibrosus, this is an important indicator for treatment response. So someone may have a positive MRI finding for disc herniation, but if we look closer and see that the annulus is in fact intact, then this person is probably going to respond to MDT. So we need to look a little closer and not just take the imaging at face value. Okay, so McKenzie proposed the dynamic internal disc model. Essentially, this is the idea that with repeated motion in one direction, say flexion, we're going to have a displacement of that disc. So a lot of times people end up with a posterior derangement. Okay, again, that mechanical pain. So this potentially puts more pressure on the mechanoreceptors, on the nociceptors. So in order to alleviate this, we go in the opposite direction, which essentially recentrates the disc or repositions it in a more central location so that we alleviate that pressure. If we alleviate that pressure, potentially we decrease pain.
So is there proof in the pudding? Many different randomized controlled trials have been conducted to assess the effectiveness of the McKenzie method compared to many different interventions in patients with a wide variety of low back pain. Over the next few slides, we will cover a few different techniques, including joint mobilization, joint manipulation, minimal education, as well as the McKenzie method and their effects on patients with low back pain. We will also discuss how diagnosis and classification of low back pain upon examination change outcomes and dictates treatment strategy. This first study, conducted by Shank et al., studied the different outcomes between treating patients with subacute low back pain with either low-grade mobilization or McKenzie exercise based off of the diagnosis of posterior lumbar derangement. McKenzie described posterior lumbar derangement as an increase in symptoms or pain with seated spinal flexion. Subacute patients in this study fit the criteria if they had been experiencing symptoms for a minimum of 7 days up to 7 weeks from their diagnosis. Patients randomized into either the exercise group or the mobilization group. Initial examination consisted of McKenzie repeated lumbar movements to provoke or reduce symptoms. The exercise group performed McKenzie exercise with a trained practitioner based on results from the repeated movement examination. Mobilization groups had passive joint mobs performed based off of their examination as well. The results of this study showed that people classified with lumbar derangement were found to improve significantly after 3 visits in both the Visualog Analog Scale with a p-value of less than 0.5 and Oswestry Low Back Scale of a p-value less than 0.03 for those who underwent a program that included McKenzie exercise as opposed to joint mobilization. Future studies should evaluate the longer effects of treatment times with these 2 interventions. Here we have 2 studies performed by Churkin et al. And Patelma et al., who studied the same 3 interventions of McKenzie method, mobilization, or take-home education on the management of acute low back pain in patients. Churkin et al. Recorded outcomes in patients who had non-specific low back pain persisting for at least 7 days. These outcomes were recorded on the numeric pain rating scale and the role and disability score measure. The McKenzie therapy was provided by a certified instructor, while the chiropractic group had the most common treatment described as a short lever, high velocity technique on the manipulable level. The education group was given a low back pain instruction booklet that included cause, prognosis, specialist care, as well as how to prevent reoccurrences of low back pain. Results of this study showed some significant change, such as the chiropractic group having less severe symptoms at the 4-week follow-up than the education group. There was also a trend toward less severe symptoms in the physical therapy group at week 4. Differences in the extent of dysfunction among the groups was small and only approached significance at 1 year, with greater dysfunction in the education group. The p-values equaling 0.02, 0.06, and 0.5 respectively. For all outcomes, there were no significant differences between the PT and chiropractic group and no significant differences among the groups in the number of days of reduced activity, missed work, or reoccurrences of back pain. Patelma et al. Also came to a very similar conclusion in their study. This study looked at acute, chronic, first, or recurrent low back pain with or without symptoms at 3, 6, and 12-month intervals. The results showed that all groups had significant improvement at 3 months. At the 6-month follow-up, the McKenzie group had more improvement than the education-only group with a p-value less than 0.05. At the 1-year follow-up, the McKenzie group had better disability index than the education-only group with a p-value of 0.028. In the orthopedic manual therapy group, at both the 6 and 12-month follow-up visits, improvements in the pain and disability index were somewhat better than the advice-only groups with a p-value of 0.067 and 0.068 respectively. The take-home message of these 2 studies may be that some form of therapy is better than no therapy at all, but what exactly works is up for debate. Machado et al. Studied the effect of the McKenzie method versus acute care education in acute low back pain patients only. Acute care education consisted of avoided bed rest, reassurance, as well as acetaminophen as instructed, while the Mackenzie group had therapy 6 times over the course of 3 weeks. Outcome measures were NRS and Global Perceived Effect Scale. The addition of the Mackenzie method to first-line care produced statistically significant but small reductions in pain when compared to first-line care alone, with a mean of negative 0.4 points at 1 week, negative 0.7 points at 3 weeks, and negative 0.3 points over the first 7 days. Patients receiving the Mackenzie method did not show additional effects on global perceived effect, disability, function, or on the risk of persistent symptoms. These Mackenzie patients sought less additional health care than those receiving first-line care alone, with a p-value of 0.002. A symptom that has not been discussed up until this point is the radicular symptom and treatment with Mackenzie method. This study by Annis et al. Studied particular cases of patients presenting with radicular symptoms due to L5-S1 lumbosacral radiculopathy who demonstrated centralization upon examination. Patients were randomized into either traditional physical therapy, which consisted of strengthening exercise, transcutaneous electrical nerve stimulation, as well as thermotherapy with laser, or the Mackenzie exercise. The mean verbal analog scale in the Mackenzie group was negative 53.53% change, while the mean VAS traditional group was 45.22% change. Mean Oswestry low back score was negative 60.83 in the Mackenzie group, and the mean score in traditional therapy was 45.44% change. Results showed that this study that Mackenzie method is more effective than traditional therapy when dealing with radiculopathy.
So let's go ahead and wrap up with some clinical pearls. A few points to consider. So first of all, let's go back to the RCTs that we were just talking about. One of the things that we need to remember in a lot of these studies is that they don't always go through the full Mackenzie evaluation as it was outlined or as it was intended. So one of the main pieces of the Mackenzie approach is to classify patients and match treatment to their classification. So if we're not going through the full evaluation, we could be missing the patient classification piece. So when they don't respond to treatment in a particular study, it may not be indicative of the potential that MDT has to affect low back pain as a whole. Instead, it's a result of just the methods that were used in the study. So we need to really remember that and critically analyze those pieces of literature when we're trying to translate that to clinical practice. Okay, one simple change you can make is to start incorporating repeated range of motion assessment into your orthopedic eval. As we talked about, this can help identify which patients will be potential responders to this type of treatment and which ones may not. That being said, we also need to remember imaging is not everything. It's not always correlated with symptoms, and so we really need to use our other assessment techniques as well to determine the best course of action. We also shouldn't be shying away from radicular symptoms. Obviously, this assessment is not meant to replace our traditional orthopedic eval, but if our red flags are ruled out, this can really be a good treatment for reducing those radicular symptoms based on the centralization idea that we've been talking about. Okay, worth noting as well, this paradigm can be applied to other joints in the body. This presentation was obviously focused on low back pain, but this can be applied to the shoulder, for example. There's more information out there in books and classes and that sort of thing if you're interested to expand this for your toolbox, but just so you know that that information is available. We also need to remember that MDT is only a piece of the puzzle. As much as we'd like to say that one paradigm can fix everything, we know that that's probably not the case. So we really need to apply our best clinical reasoning to match our treatment decisions with the patient needs and their unique situation. Last but not least, this paradigm is great for increasing patient autonomy and ownership because they really have control over their pain at this point. They are applying the treatment for themselves. They have control over how much range of motion they go through and that sort of thing. So it can be really empowering for the patients. Okay, sorry that went a little over, guys. That went a little long. But thanks for listening and hope it was helpful.